Hi there, I'm Dr. Richard Finn from the Geffen School of Medicine at UCLA, and thank you for joining me for this short ESMO highlight conversation on some data of relevance in the liver cancer space. I think one of the biggest presentations of the meeting was the LEAP-012 study. This was the primary results of this randomized phase 3 study looking at the combination of lenvatinib and pembrolizumab with chemoembolization versus placebos and chemoembolization. The primary endpoint here was progression-free survival in this population of patients that was mostly intermediate stage liver cancer. This study reads out a few months after the EMERALD-1 study, which was looking at bevacizumab and durvalumab in combination with TACE that was presented at ASCO GI earlier this year. This study did meet its primary endpoint with an improvement in PFS with a hazard ratio of 0.66. That was an improvement from 10 to 14.8 months in regards to the absolute delta in progression-free survival. These data were statistically and I think clinically significant. Also presented was the overall survival data at the time of this analysis. There were not a large number of events at this time, so this is considered somewhat immature. And the hazard ratio there for overall survival is 0.8. Again, this was not statistically significant at this time. Putting this in context, obviously we will need to see regulatory approval here, but this does suggest that adding medical treatment on the backbone of local regional treatment may play a role in managing these patients and delaying progression. This is not a curable disease, but perhaps we can extend their time to becoming advanced. We will want to see further follow-up, obviously, to see if we actually improve overall survival. And in contrast to the EMERALD-1 study, in this case, the anti-angiogenic lenvatinib was started before the chemoembolization, and this may have a greater effect on the combination than starting in EMERALD-1, the bevacizumab, after completion of chemoembolization. Also, I'd just like to comment that we saw an increase in the objective response rate, just under 47% with the combination versus 33%. The other study that read out at ESMO 2024 that I think is of some clinical significance was the follow-up from the IMbrave050 study. You'll remember that 050 was the adjuvant study of atezolizumab and bevacizumab, which was presented at AACR 2023 and subsequently published in Lancet, that evaluated atezobev after surgery for patients who are high risk for recurrence. This is the first of several phase 3 studies in this space to read out, and the study met its primary endpoint of decreasing the risk of recurrence. The initial readout was with a median follow-up of about 17 months with a hazard ratio of 0.72, which was statistically and clinically significant. Now at ESMO 2024, we saw that with longer follow-up, now 35 months, almost 3 years of median follow-up, the curves actually come back together. And we've lost this benefit of delaying recurrence. This is disappointing because we had a regimen that looked like it was delaying recurrence for this group of patients. However, with longer follow-up, we see that benefit is not retained. There are other studies being evaluated in this space. Atezobev, as you know, is approved in advanced liver cancer because of its significant improvement in OS. However, at this point, we can't really recommend this regimen for intermediate stage HCC, or I should say early stage HCC after resection. Finally, we'll just comment briefly on 2 additional data sets that were presented. One, we saw additional follow-up from the Himalaya study, now 5 years of follow-up of this study looking at durvalumab and tremelimumab in advanced liver cancer. And at 5 years, we see a maintained survival benefit. Actually, 20% of patients are still alive that received durva-tremi in frontline HCC, and that is significantly better than the 9% that we saw in those patients who got sorafenib. And finally, we saw encore presentation of the 9DW study, which was presented at ASCO 2024, and that was the evaluation of ipilimumab and nivolumab versus a TKI, either sorafenib or lenvatinib. This study revealed an objective response rate of 36% and a hazard ratio of 0.79, or a 20% decrease in the risk of death. In closing, we should remember that both of the CTLA-4 and PD-1 studies, 9DW and Himalaya, did not include patients with main portal vein invasion, unlike the CARE study or the IMbrave050 study, which did take those patients and still demonstrated an improvement in overall survival. So the HCC field continues to develop rapidly, and I'm sure we'll have more data to discuss in the coming months. Thank you very much for joining me.